Good evening. Thank you all for joining us on the webinar. I am Venkat Tumala. I'm an interventional radiologist and Associate Chief Medical Officer at Penumbra. We're going to be talking about evolving data and technology in regards to advanced catheter-based therapy for pulmonary embolism. Joining me today to share their thoughts and wisdom, we got three esteemed faculty, and it's my absolute pleasure to introduce them in the order of their presentation tonight. First, we got Dr. Ido Weinberg, vascular medicine specialist from Mass General Hospital. Thank you, Ido, for joining us, especially from the other side of the pond. So I know it's late and appreciate that. And then we got Dr. Razowski, Director of Thrombosis Research at Mass General Hospital, Associate Professor of Medicine at Harvard Medical School. Thank you, Rachel, for being part of this. Last but not the least, my neighbor to the north, Dr. Brett Wakeman. He's an interventional radiologist, been in private practice for a while, and he's practicing in Gainesville, Florida, with vascular interventional physicians. Great to see you, Brett. Thanks for being here. And we're going to have a fun discussion here, all topics around data and CAVT technology. And if there are any questions, please post them on the webinar. We'll get them answered between talks or towards the end as well. With that, I'll hand it over to Dr. Weinberg to kick us off with historical data and evidence gaps, as well as risk stratification in PE.
All right, thank you. Thank you very much for having me, and it's an absolute pleasure to be able to participate in this. I'm going to try to share my screen, and I'll try to get into presentation mode. Here we go. I hope you're all seeing what I'm seeing, and I'll be covering over the next about 15 minutes as you can see here, pulmonary embolism historical data, evidence gaps, and risk stratification. Let's see what we can get through. These are my disclosures. And so, I was charged with historical data, and I thought to make it a little fun, and I went like all the way back as far as I could find. And as you can see here, basically, pulmonary embolism as an entity wasn't truly described as far back as I've shown here, but you can see that Hippocrates did mention what sounds like DVT and what also may progress to death. So it definitely sounds like a complication that had to do with pulmonary embolism. Galen, later on, but still very early on as far as we're concerned, also discussed what seemed to have been DVTs, right, with vessel occlusion, limb swelling, and pain. More into the sort of 16th century or the 1500s, pulmonary embolism was actually described, clots from the veins carried to the heart and lungs, causing instant death. So that's the way it was perceived back then. Laennec, who was the person who invented the stethoscope, basically described pulmonary apoplexy, this morbid affliction as evidently produced by an effusion of blood into the parenchyma of the lungs, in other words, into the air cells. So that sounds pretty much like a PE as we would describe it today. 1829, I couldn't get the exact quote, but this everybody quotes, when you read about the history, everybody quotes this paper, so I've also kind of included that. And then finally, Virchow in 1858 basically called it, what it was. Thus, we see that as a rule, all the thrombi at the periphery of the body produce secondary obstructions and metastatic deposits in the lungs. So, people have over the years really taken a lot of interest in pulmonary embolism, and it was obviously perceived as a catastrophic event, and that's the way it was seen over the centuries, I guess. The morbidity and mortality data are more what the organizers of the session wanted me to kind of look at. And truthfully, despite this sort of historical perspective, most PE patients do well. If any of you have ever seen any kind of general talk about PE, you've seen this slide or a similar slide to it. Basically, what you see here is that the pulmonary emboli that are most common are those that are in patients who are either asymptomatic or have mild, either no right ventricular dysfunction or just mild kind of findings, and their overall mortality is overall low. So pulmonary embolism does not need to be the catastrophic event that was described sort of historically, and most PE patients do well. The incidence of pulmonary embolism seems to be similar across various studies. This colorful slide here is a modern Polish national sort of cohort, and this black and white graphic here is a much older Olmsted County, Minnesota data, from 1966 to 1990, as opposed to this more modern series that looked at the late 2010s into the 2020s. But overall, you see here that it seems like the incidence of PE remains rather similar at 50 to 70 to 100,000 population. Despite what I showed you before, it seems like sudden death can be explained by PE more often, quite often. In iCopper, for all comers, they looked at about 2,400 patients from many centers around the world. And for all comers with PE, all-cause mortality actually exceeded 15%. So those patients with pulmonary embolism who present for medical care had a considerable, in the 1990s, considerable mortality rate, as you can see here. Of those, nearly half were considered PE-related mortality, as you can see. That's the iCopper data that kind of reflects sort of your typical 1990s sort of medical approach. The same Polish data from before, the more modern data, you see here that, again, mortality is in the same range as I've shown you before. This is all-cause mortality, not necessarily PE-related mortality. But PE, if not the cause of mortality, is definitely a marker of badness when it appears. PE are more common with age, just trying to talk more about the epidemiology and natural history. This is, again, the Olmsted County data. And obviously, as patients were older, the incidence of PE rose considerably. Now, again, I tried to kind of find the original data about treatment of pulmonary embolism, and I came across this seminal paper published in Lancet in 1960. This was the first time anticoagulation was used in patients with pulmonary embolism in an organized fashion. Only 38 patients, that's all it took back then to get into Lancet. Half of them received anticoagulation, and half of them did not. And those who did not receive anticoagulation at a very high mortality rate, while obviously those who were treated with anticoagulation at a much lower mortality rate. It's interesting to read the methodology of this paper. Basically, the authors kind of write that they went to all their colleagues and asked them to call them immediately when they suspected PE in a patient. And so that was their recruitment strategy back in the day. Moving on. And here we go. Patho, a seminal paper looking at patients with submassive pulmonary embolism receiving IV lysis. This was a large study with over 1,000 patients randomized either to tenecteplase or to placebo. And what you can see here that while there wasn't a mortality advantage for the patients who received the more aggressive IV lytics, patients who received the lytics had less treatment escalation in a significant manner. However, the cost of this was excess bleeding. And as you probably know, and my co-presenters will talk more about treatment, but as you probably know, IV lysis in patients with sort of intermediate risk, those patients at the middle of the pyramid, is not a standard therapeutic option. The Ultima study randomized 59 patients into two groups. It was published in Circulation in 2014, led by Niels Kutscher. Basically, what the patients received, both groups of patients received anticoagulation with heparin, and then half of the patients received ultrasound-assisted thrombolysis or ECOS with an ECOS catheter. And what you see here is basically that while the RV2 LV ratio normalized more quickly in the patients who received the more aggressive treatment, by 90 days there was a catch-up effect. But there wasn't much functional data tied to this. This was a study that looked mainly at this metric and not at more granular information as we typically do look into nowadays in modern trials. I do want to say that more aggressive treatment with interventional therapies for patients with pulmonary embolism, even if it's a catheter-based therapy, as opposed to the IV lytics that I showed you with Patho. Still, bleeding can occur, and as many as 10% of patients had what was designated as a minor bleeding event. I was very lucky to be included in this meta-analysis of patients with intermediate risk or submassive P, as they were known back then, patients who received a lytic therapy. And what this meta-analysis showed, what we were able to show, was that overall there was a mortality benefit for patients who did receive the lytic therapy in patients with submassive P. I will just say that you have to know the numbers because the way these meta-analyses work, for those of you who don't know, you kind of assign weights to various outcomes, and the weight that was assigned for intracranial hemorrhage was such that it showed a benefit towards mortality. But if we had assigned a higher weight for major bleeding and specifically for intracranial hemorrhage, maybe the small numbers needed to treat that you can see here would not be as optimistic as this table makes them to be. So what, back to more ancient history, in the New England Journal of Medicine in 1967, discussing the natural history of pulmonary embolic disease, they actually said that when you take all comers with pulmonary embolism, improvement or complete recovery of pulmonary blood flow occurred in many patients with pulmonary embolic disease. It gives support to the growing clinical impression that pulmonary embolectomy, which was the invasive treatment of the day, should be restricted to patients who are unable to maintain their circulation despite vigorous medical support. And I want to say that I'll show you data that we produced in a second, but I'll say that back in 1976, again, they said that the most important factor affecting mortality was shock due to acute right ventricular failure secondary to massive P, and they showed a mortality rate of about 32% in those patients. This was in 1976. And the reason I showed you these two papers because Eric Szemski and I, we published our data, and we basically showed very similar mortality rates to what they showed, 50 and 60 years before what we published, right? Is it more of the same? Have we not been advancing since the days of Hippocrates, and have we not made any progress in this field? Well, even though these mortality figures seem familiar from these older publications, we did show that some patients still did benefit from intervention. So it seems that there's a matter of pairing the correct intervention to the correct patient, sort of identifying the correct patient who needs the intervention and pairing the correct intervention with that. And one classic example is the use of ECMO, which became more prevalent in the sickest of PE patients. And what you can see here is that by utilizing ECMO in the sickest of patients, survival increased significantly. And it's a lot of that was because it stabilized patients just long enough for other aggressive therapies to be made possible. And what is the natural history of these patients with massive P, the sickest of the sick? Well, the only true randomized trial of the day kind of compared IV lytics to anticoagulation alone, and basically there was only mortality in the patients who did not receive the lytics, because not treating these patients aggressively would be akin to jumping off a plane without a parachute. So what about catheter-based therapy? So I used to say that you should only consider it in patients with massive P if you're able to implement these therapies very rapidly. And I used to say that most centers were not able to do so, and that IV therapy was probably still a very relevant therapeutic option to think about. And then came these data, that Penumbra produced through the Strike PE program, where these were presented at TCD and at VITH this year, just recently. And high-risk PE patients, with confirmed either systolic blood pressure under 90 or a drop of 40 millimeters of mercury for at least 15 minutes, or vasopressor support or cardiac arrest. These are definitely high-risk patients. There was a much higher, a much lower, adverse event rate, and the mortality rate, if you kind of look over here, was much lower than we had seen historically. And there's a lot to be said about these data. This is not the purpose of my part of the talk. I just want to say, if you look at these data from the historical perspective and from the natural history perspective, they're definitely quite impressive. So what about the evidence gaps that I was asked to address? They exist across the PE patient sort of patient journey. And from the initial assessment through the interventional management, through the hospital monitoring, and then post-discharge, there's just so many gaps in our knowledge of how to manage PE patients. And we just don't have enough time in my 15 minutes to go through all those. But if you kind of read this reference, you'll be able to kind of dive deeper into these gaps. And like I said before, allocating correct treatment based on non-hemodynamic parameters is not always easy, and there's definitely a need to understand these things better. And I'm sorry, I jumped too quickly. And you can see that there are gaps, clinically relevant gaps, when you're trying to tailor the correct treatment for the correct patient, from assessing a particular patient's bleeding risk through understanding exactly which non-hemodynamic clinical markers are relevant for the patients, and understanding what is your impetus for every type of treatment that you offer the patients. Is it only sort of acute symptom resolution, or is it also long-term outcomes? And finally, in just a minute or so, risk stratification. Well, there are many markers that we know to follow, and these markers on the screen here, from the RV to LV ratio all the way to the lactate levels, are associated with PE-related mortality. We know we need to follow these. And then, and what you see here is the sort of the how powerful or lack of power of each one of them on its own, but you can combine these markers to understand the severity of illness in your patient. And then you can combine these into tools to risk stratify the PE patients into categories. And what you can see here is that we do know how to risk stratify patients. We do. There are, you can find this online, and we know that we have the Hestia criteria, we have the PESI criteria, etc. Very easy to use tools that are very well validated. But when you want to truly understand how to use these to predict decompensation in a particular patient, it is much harder. Even the BOVA score that predicts 30-day PE-related complications, it still doesn't help guide us. So there's a large gap there also in utilizing these tools. So I think that is towards the end of my time. And so I will just end by saying that there are many gaps that still need to be bridged. And with that, I'll stop sharing my screen. And I think the next speaker will be up.
Well, thank you, Ido. That was wonderful, walking us through the journey from the 16th century to the current times, and a wonderfully done job about the gaps, the evidence gaps that we're all seeking to answer. As much as the disease state has been around, and we talked, we're seeing all this progress with technology as well as the data, and which Dr. Rozowski is going to talk in a second here, failure to diagnose is still a considerable factor, right? When it comes to PE being a big masquerader. Any thoughts on how that should be? Do you see that quite still? How do you tackle it?
Were you asking me? I'm sorry.
Yes, yeah. I was saying failure to diagnose is still a big challenge. How do we address that?
Well, it's funny. I was saying when we were sitting together before the meeting started, I was saying that I gave a talk today at a different conference, and that was a question that seemed to interest many of the people attending the conference. I don't know that I have a very kind of strong answer to that because I don't think it has changed what we learned in medical school, right? You need a high level of degree of clinical suspicion. You need to remember that patients present in multiple ways. Many patients can be asymptomatic, like I showed in that pyramid graphic. Patients can have very mild symptoms, sort of a little cough, a little pinch in the chest, a little shortness of breath. And then on the other side of the spectrum, patients can come in cardiac arrest, sudden death, and everything in between. So the bottom line is there needs to be a high index of suspicion. I think that especially in the emergency room, but also in sort of in hospital, sort of medical floors, etc. And of course, at risk populations, immobile patients, patients being exposed to hormones, either pregnancy or hormone replacement, patients with malignancy, etc. Just a high level of clinical suspicion is necessary, and then at least sort of taking that and knowing how to move forward with that to make the diagnosis and not miss these patients, because when you do miss them and you delay treatment, then you move from the lower, sort of the advancement to the lower mortality. You kind of scroll back to the old days where mortality and morbidity were very high.
Great point. High index of suspicion, not just in the ER, but anywhere across the hospital system, right? These patients can be presenting. So let's move on to our next speaker, Dr. Razowski. She's going to talk about current clinical data for PE, including the landmark STORM PE trial.
Yeah. And just to go along with that high index of suspicion and misdiagnosis, there was a recent meta-analysis of a few thousand patients where they looked at misdiagnosis in the emergency room, on the wards, and then in the ICU. They did autopsy data on the people that died, and it ranged anywhere from a third to a half. So I think it is just critical. And I think one of the issues, as Ido mentioned, is that as Ken Rosenfield likes to say, PE is the great masquerader, right? There's not like one symptom that says you have a PE. So I definitely think having that high index is so critical. So I just want to thank the Penumbra and Chest for inviting me to speak at this webinar. Real honor and privilege. And on behalf of the entire STORM PE investigators, of which Ido is one of them, I'm thrilled to share with you the randomized controlled trial of mechanical thrombectomy with anticoagulation versus anticoagulation alone for acute, intermediate, high risk. I'm going to talk about the primary outcomes as well as functional endpoints and core lab findings. And this was we presented our primary outcomes at TCT and then our secondary outcomes at Viva just a few weeks ago. These are my disclosures. So just a little bit of background. I don't think we need to spend a lot of time on this, but as Ido mentioned, pulmonary embolism is a major cause of morbidity and mortality, about 1 in 1,000 adults globally per year. It leads to considerable socioeconomic burden, reduced functionality, and quality of life. As Ido already mentioned to you, there's different risk categories, and we know that the intermediate high-risk PE patients, those are the ones with the elevated RV-LV ratio, in addition to the cardio biomarkers, have a greater than twofold increased risk of mortality and a risk of early decompensation. So there are huge evidence gaps. Ido already showed you the one and only randomized controlled trial of anticoagulation versus no anticoagulation for the treatment of PE, and that led to it being the mainstay of therapy. Ido also showed you some other trials. The last completed randomized controlled trial of any device versus anticoagulation in this space for this population was over 10 years ago, and functional outcomes of mechanical thrombectomy versus AC is unknown. So STORM PE is the first ever randomized controlled trial evaluating mechanical thrombectomy and in particular CAVT plus anticoagulation versus anticoagulation alone. This is a trial that was sponsored by Penumbra and in partnership with the PERT Consortium. So this slide shows you the key eligibility criteria and trial design. On the left is the inclusion. Importantly, patients presented with less than 14 days of symptoms, and they had to have a CT showing a filling defect in the main or proximal lobar pulmonary artery. And as I said, elevated RV-LV ratio and elevated cardio biomarkers. On the right, you can see it was 100 acute, intermediate, high-risk patients. 47 were in the CAVT arm plus AC, 53 were in the AC arm alone. This was an international study with 22 sites. The primary endpoint, as you can see in that bottom box, was the difference in RV-LV ratio change within 48 hours. This was adjudicated by a blinded imaging core laboratory. The secondary safety endpoints were major adverse events within 7 days and safety outcomes within 90 days, and those were adjudicated by a clinical events committee. Secondary endpoints were also functional outcomes and quality of life at 90 days. So this slide goes through the visit schedule and data collection. Standardized treatment was initiated within 24 hours from baseline CT and less than 12 hours from randomization. And at each time point, you can see what data was collected. In the bottom gray box, it goes through the quality and functional assessment. Importantly, both groups were very well matched across key baseline measures. You can see here demographics, race, medical history, index PE presentation, they were exactly the same. And what I've highlighted here in the red box is that the baseline clinical parameters like heart rate, oxygen, that RV-LV ratio, thrombus burden, as well as baseline functional assessments were well matched as well. Now, this procedure is safe, fast, and effective. The thrombectomy time was low, 25 minutes, minimal blood loss, 100% technical success. There were 0 device or procedure-related transfusions and no access site complications. So this was our primary efficacy endpoint. Just to remember that change in RV-LV ratio at 48 hours. And you can see here, the red is going to be the CAVT plus AC arm moving forward. The gray is the AC arm alone. And you can see here there was a superior reduction in the CAVT arm in that ratio from baseline to 48 hours, with a relative reduction of 29.7% in the CAVT plus AC versus 13% in AC. And the between group difference in absolute reduction was 0.27. Importantly, when we looked at the secondary safety endpoints through 90 days on the left, safety comparable endpoints were comparable in both arms. On the left, you can see here 3 people in the AC arm deteriorated, requiring rescue therapy. There were 2 PE-related deaths in the CAVT arm, 1 major bleeding in each arm, 1 major bleeding requiring transfusion in each arm, and 1 symptomatic recurrent PE in each arm. On the right, you can see there were comparable 90-day safety rates. The all-cause mortality and the PE-related mortality were the same. There were no device-related mortalities, and there were no PE-related mortality greater than 7 days. So it was effective and safe. And now I'm going to get into the more physiological parameters. So this is the change in thrombus burden at 48 hours. And just to orient you to this slide, the black is a higher degree of thrombus burden, the red is less. On the left, you can see baseline, on the right is 48 hours. The top is the CAVT and the bottom is AC. And you can see here in the baseline in both CAVT and AC arm, there's a comparable degree of thrombus burden, and it's pretty significant. But note at the 48 hours that there's significantly larger reduction in that mean thrombus burden in the CAVT arm, almost 2 times reduction. So 42.1% relative mean reduction in the CAVT arm versus 15.6 in the AC arm. So less thrombus burden. What about heart rate and tachycardia? On the left is the mean heart rate, and you can see here at randomization they were the same, and there was significantly lower heart rate at 48 hours in the CAVT arm, 80 versus 86. And on the right is tachycardia, that's heart rate greater than 100. And again, you can see at randomization they were the same in the 20s. At 48 hours, 2.2% in the CAVT arm were still tachycardic versus 20% in the AC arm. Oxygen requirement, again, you can see here in the red that the mean supplemental oxygen at 48 hours was 0.5 versus 1.4 in the AC arm. So significantly lower supplemental oxygen requirement in the CAVT arm at 48 hours. What about the NEWS score? So the NEWS 2 score is a composite score that indicates the risk of clinical deterioration. On the right, you can see the components of the NEWS score. The lower the number, the lower the risk. The higher the number, the higher the risk. And you can see here that the CAVT arm had a significantly lower NEWS 2 risk at 48 hours, 1.8 versus 2.7. When we looked at the Borg and MMRC dyspnea scores, there was no significant differences in either of them between arms at discharge. And then what about functional endpoints? Well, there's something called PVFS, which is post VTE functional scale, and it's a functional limitation ordinal scale, which focuses on aspects of daily life. And what we asked is, what is your pre-PE PVFS? What is your baseline, which is at presentation? And what is your discharged? And you can see here that the CAVT patients were a little bit more than 2 times more likely to move toward their pre-PE functional status, which means significantly less change in PVFS score from pre-PE event to discharge. And then lastly, 6-minute walk test. So on the right is the mean 6-minute walk distance in meters at 30 days and 90 days. And you can see here at 30 days, although the CAVT arm was a little bit higher, there was no statistically significant difference at 30 days. But at 90 days, you can see that the CAVT patients walk significantly farther at 90 days. And on the right, you can see here that the CAVT patients had almost a twofold, 2 times improvement in walking distance from 30 to 90 days compared to AC alone. So I think this is pretty significant because at 30 days, they were the same, but at 90 days, so 3 months after their PE, there was significant difference in their ability to walk. And so I think that just points to the long-term effects that this procedure can have. When we look at the percent of predicted 6-minute walk test at 90 days, so predicted walk distance is normalized for sex, age, and body surface area. And again, you can see here in the red that the CAVT patients were able to complete significantly more of their predicted walk distance than the AC, 94% versus 75%. So in conclusion, the STORM PE is the first randomized control trial to report the results of mechanical thrombectomy with anticoagulation versus anticoagulation alone. The CAVT arm demonstrated superior reduction in the RV dilatation with importantly, a similar safety profile to the AC arm. I shared with you that treatment with the CAVT resulted in early physiological recovery and greater reduction in pulmonary obstruction compared to AC alone. We talked about thrombus burden, heart rate, oxygen, and the NEWS2 score. And the patients with CAVT demonstrated greater improvement in functional outcomes, both PVFS and at 90 days, that 6-minute walk test. So these promising results reinforce the role of mechanical thrombectomy, specifically CAVT, as an effective treatment strategy in patients with acute, intermediate, high-risk PE. Very exciting. And you can read our primary outcomes from the STORM PE trial in circulation if you follow this QR code. We are working on the secondary outcomes now. And I just want to point out that this would not have happened without all of the investigators from around the world, the hundreds of patients, and of course, it was in partnership with PERT Consortium. So definitely want to shout out and thank, as well as our Blinded Independent Imaging Core Lab, our CEC, and our Data Safety Monitoring Board. And then our STORM PE steering committee was unique in that it was multidisciplinary. So we tried to get all the disciplines involved in PE care. And importantly, we also had a patient on the steering committee because we felt very strongly that we wanted their perspective on what is important. And what I didn't share with you, and we're analyzing this right now, is each patient was offered a Garmin watch. And so and they wore it for actually 90 days. And that's really kind of a treasure chest of what we're going to potentially find in terms of how their physiological recovery, as well as looked at sleep and activity and exercise. So that's going to be very helpful. Okay, so what is next? So I think there's still, and Ido shared with you some gaps in PE treatment, and I still think there's huge gaps in PE treatment. And one of the things that was sponsored by Penumbra earlier this year was something called Get Out the Clot Survey, looking at the state of VTE care. It was 269 physicians who treat VTE. It was both interventionalists and non-interventionalists. And the aim of the study was really to try to understand trends in care. This was through the American Venous Forum, ISTH was involved, National Blood Clot Alliance, Penumbra, PERT, and SVM. And in the survey, we found that greater than 50% of the physicians surveyed said they do not have a formal response team at their institution. We didn't have the time to go into this, but we know that PERT teams, which are now in the European guidelines, decrease time to diagnosis, decrease time to anticoagulation, decrease IV seed filter use, decrease cost, decrease length of stay, and some of them even show improvement in mortality. 35% of the survey participants perceive the ultimate decision to be made by consensus among specialists, which means 65% are not and doing it in isolation and alone. And only 56% of the interventionalists surveyed believe that their protocols provided clear direction based on PE risk beyond medical management, and treatment approaches varied even for patients with the same risk profile. And what Ido shared with those gaps, that came out of our Pulmonary Embolism Research Collaborative. And I think it's critically important because we need to have standardization of diagnosis, treatment, follow-up of outcomes, and long-term follow-up. And so this survey really highlighted those gaps. And one of the ways we're addressing those gaps is we've launched a new program at PERT called PRISM. It stands for Pulmonary Embolism Research Improved Care, Standardized Systems, and Measured Outcomes. And we want to help institutions get PERTs. And so we have something called PERT Partners. We can help you establish a PERT. PE Centers of Excellence. So what Ido showed, that paper in circulation, that was kind of the launching pad of creating these PE Centers of Excellence. And we have about almost 50 or 100 now that we're in the process of doing that. The PERC database, which is probably the single largest PE specific database there is. Ido mentioned the iCooper registry. Well, this one has far surpassed that. I think we have 15,000 patients in that database. So really helping programs get involved in that. And then PERT Search, which is something we mentioned earlier about diagnosis. We know that about 50% of PEs are diagnosed in the ER. So really engaging those first responders is integral to early diagnosis, treatment, and triage. And this is being sponsored by a number of different industry and partners, and really launched with the help of Penumbra. And then lastly, we'd love for you to join us in our 12th annual Pulmonary Embolism Scientific Symposium. It's going to be in Boston. It's a 2.5 day with hundreds of speakers from all over the world, experts. It's a great way to learn the most up to date in what's going on in PE, in addition to this amazing webinar, and also just to network and get involved in some of the research projects, education programs. We also have a trainee council. So if you have early careers, we'd love to get them involved. And then we launched something called PERT International, and we have about 20 countries that are now involved. So again, want to thank Penumbra and Chest for inviting me, and happy to answer any questions.
Thank you, Rachel. Great initiatives, and I know there's a lot more to go. Congrats to you and all the investigators and the committee for a successful execution of this landmark trial. Definitely a leap, a giant leap in the right direction. We talked about several things in this trial. Just to highlight them, you mentioned how fast the device is, the safety profile comparable to a non-interventional arm, and knowing that the enrollers, even the highest enrollers, had only 1 or 2 case experience prior to enrollment. How do you think that should translate towards, as of today, if there is an intermediate high-risk PE patient presenting, how does this safety profile and the various goodies that we saw in the trial, factor into decision making?
Yeah. So thank you for asking that. And, Ido knows this. We'll sit on our PERT calls and we'll have a patient come in. And up until now, we didn't have the level 1 evidence to say something is better than anticoagulation alone. We just didn't. We had a lot of single arm studies that showed, yes, it changes RV-LV ratio. Yes, it might have these other outcomes. This is the first randomized controlled trial, level 1 evidence that actually shows that there is not only early physiological recovery with adding this device, but also improved 90-day outcomes. And I think what is critical is that the safety was the same, and each operator, all they had to do was 2 of them before they could start enrolling patients. So I think it's an easy, I'm not an interventionalist, so I can't actually say that it's actually easy, but the fact that they only required 2, and there were no device related adverse events. So as a non-interventionalist, that's what I want to know about. And so I think that should make people very comfortable. I think the issue is going to be, how do we get this message out, right? Because, the interventionalists go to the conferences and hear about that, but really getting to our first responders, because those are the people that see the patient first and start to say, okay, what's available? What am I going to treat you with? And so I think this is a really exciting trial. There are several, I think 4 or 5 other randomized control trials that will be coming out of the next year or 2, which I think will continue to add to the space. But I think now we have the evidence to really help our colleagues present to patients like, look, we have this trial. This is going to help you recover faster. You're going to, have less oxygen. You're going to feel less short of breath. You're going to feel less, and not short of breath, that was the same, less tachycardia, less thrombus burden, and then feel better in terms of functional status.
Excellent. Luckily, we have an interventionalist on the call, so I'm going to pull in Dr. Wickman here.
Very good.
So your take on it, Brett, and before we hop on into your talk.
Yeah, no, I think all those are all good points that Rachel made. Certainly there are easier pulmonary embolus thrombectomy cases and more difficult ones, and I think that that evidence is critically important to just being able to speak to either patients or physicians who may be questioning the value in early intervention in terms of device type intervention, mechanical thrombectomy, et cetera. So I think it's starting to fill these evidence gaps that we've heard about so far tonight. And as Rachel mentioned, there's going to be more to come. So excited to hear about the results of those studies as they mature.
Awesome. Thank you for that. And one quick question before we transition to your talk. We've seen thrombectomy times under 30 minutes in this study, right? Procedural times on an hour. Is that in keeping in your experience? Is that similar experience that you have in practice?
Some of the time. I'll just say it that way. Some of the time. Sometimes these patients are quite complex. So there's device time and then there's procedure time or time on the table. And so as the technology has gotten better, more efficient clot capture, I think that the actual device time, which is a good portion of the critical part of the procedure, quite honestly, as the devices have improved, then that time has shortened. Certainly, there are more challenging cases with sicker patients and maybe funny rhythms that develop as you're crossing the heart. So all those things come into play. It's not really the clot capture that is the longest part of the procedure time. It's everything else that goes along with it. Sometimes these arteries are difficult to catheterize. So,
yeah, absolutely. I think we can all agree on one thing, though: the less time on the table, the better off it is, right? As long as we get the job done and safely. Awesome. So let's look at your experience, your case experience with CAVT, and maybe we can answer a question or two after your presentation.
Sure. Let's get to presentation mode here. So we're going to get very practical here. Tremendous update on the evidence gaps that exist and where we're going with the field. Tremendous recap of the history and where a lot of this, the shift to treatment, where it started, where we are now. So I'm going to talk about patients and how they present. I'm going to show you a quick case, and then probably something that is neglected more than we care to admit as interventionalists, and that is, what do we do with these patients afterwards? Critically important in terms of what we do when we're done with the case. So who's at risk? We talked about this already, and it was already well covered. But there are certainly patients that are at higher risk, whether you've got previous VTE, if you are on hormone replacement therapy, if you're in a situation where you're immobilized, long ICU stays, or patients that are immobilized in the lower extremity, like from a previous hip replacement or a knee replacement surgery. Chronic conditions, family history, obesity, all these things add to the risk factor, the risk profile for patients for PE. How do they present? We've talked about this at length already too. The great masquerader. Most of these patients at some level have a component of chest pain, and it's very often described as worse with deep breathing, kind of a sharp stabbing pain, or what we would call typical pleuritic type chest pain. Certainly shortness of breath, dyspnea on exertion, can't walk from here to the kitchen without gasping for air. Sometimes patients have a cough. Sometimes it's a bloody cough. Many of my patients, certainly, I feel like this is a very common symptom. They describe this lightheadedness or dizziness. Sometimes it's associated with anxiety, or what we all learned in medical school, which is this sense of impending doom. They feel like something is definitely wrong with them. They don't know how to describe it, but they have that anxiety. The signs that we see in the emergency room or in the ICU, or from a patient that comes from the floor, you see listed here. There's They're certainly hypoxic. They can be very tachycardic. In fact, that's one of the things that scares me the most when I'm entertaining whether or not we need to do intervention. If they've got a rapidly accelerated heart rate from their baseline, that's a sign that might tip me more towards treating these patients earlier. They can become quite hypotensive. This is when we're flirting with that area from submassive or intermediate high risk to high risk. Old term there, sorry to throw that in there. Getting away from the submassive and massive into the intermediate risk and high risk. Many of these patients are rapidly breathing. They can't catch their breath. They can't complete full sentences when you're talking to them. They can be very diaphoretic. But as we mentioned, not all chest pain is pulmonary embolus. This is a short differential diagnosis, but one of the things that we have to exclude or at least entertain as a possible diagnosis is acute coronary syndrome or aortic dissection. Less likely pneumonia and pneumothorax. Those are a little bit more associated with other symptoms that you can hopefully use to differentiate it, but certainly within the differential for chest pain and things like pericardial tamponade. So this is in general how most of these patients present from the list of, on the slide here. They're going to have at least one, if not several of these symptoms. I'm going to present to you a patient that checks some of these boxes. So this is a patient who's 74 years old. He's obese, but no previous history of VTE. But he's a truck driver, and he was recently on a long haul. He admits that he has a very inactive lifestyle. He doesn't have a regular exercise regimen, but he presents with acute shortness of breath, chest pain, lightheadedness, and just describes something not being right. He doesn't feel well. Declined any symptoms of lower extremity swelling, so no kind of prelude to this, the acute syndrome here. He's tachycardic. He's got systolic blood pressure of 110. And he's on 92%. He's at 92% on 4 liters. When I talk to patients here in a controlled environment like this, where he's not hemodynamically unstable, I'll actually take their oxygen off and see if they can talk to me in complete sentences and what their oxygen does when I've turned the oxygen off. You can see the biomarkers listed here, and then just the list on the right here. He checks some of those boxes. He doesn't have cancer, but he is overweight. He does, 74 is that advanced stage. That is up to to whoever wants to decide the exact age there. No previous history of DVT, but he was somewhat immobilized because he is a truck driver recently on a long haul. So as most patients with these symptoms in the emergency room, they will get a CT pulmonary angiogram. I put the circles here on the significant obstructive clot here in the right lower lobe. You can see that he's got a pulmonary infiltrate as well, but perhaps more importantly, he's got not only a thrombus here on the right, but significant occlusive thrombus on the left, and is typical for our program and most PD response teams. We measure RV-LV ratio. This is elevated above 0.9 is felt to correlate well with the echocardiographic signs of right ventricular strain. There's a saddle component to the pulmonary embolus, as you can see here as well. So in this slide here, we can see that this patient is clearly at intermediate high risk, meets all these markers with checks all the boxes with elevated biomarkers, elevated RV-LV ratio, and somewhere in that 20 to 30% short-term mortality at 90 days. So this is the patient that we take to the lab for intervention. He's very cyanotic, though, when he lays supine. In fact, the nurse is a little bit concerned about this when we did this patient, because his color when he comes into the room, angled at 30 to 40 degrees, is actually not bad. But when we lay him flat, he gets very supine. And we approach this from a femoral approach, and you can see that there's a significant thrombus burden here in the distal aspect of the right pulmonary artery. Resting pulmonary artery pressure here in the main pulmonary artery, 52 with a mean of 35. So these patients are sometimes have markedly elevated pulmonary artery pressures. Sometimes they only have moderately elevated pulmonary artery pressures. You can see a better view here, and this is before we did any. Ignore that the bottom line there. This is pre, but the next image that I'll show you, you'll see that the significant difference here. So this is a large, bulky obstructive clot. And this is no doubt contributing to his hypoxia and the increased right ventricular strain by biomarkers and by CTA. So this is after a single pass made with computer-assisted vacuum thrombectomy. This is what's called the Flash 2.0 device. So it's a 16 French device that we deliver through a right femoral vein approach. You can see just on the lateral side of this over here, the big filling defect here in the distal left pulmonary artery. And here's just a close-up view of that obstructive clot. You can see very little filling of the left lower lobe pulmonary arteries, some intraluminal filling defects here as well in the medial basal segment here, but predominantly the culprit here is this obstructing thrombus in the distal left pulmonary artery. And this is what's missing here. As we make one pass, we still have residual thrombus noted in the pulmonary artery here, but what's missing is this posterior basal segment that's outlined here in the red. This is an additional pass, and you can see that we can clear out this segment here, might get much better perfusion, and there's a tiny little nugget hanging here at the end of the catheter that we can aspirate back out as well. Cyanosis resolved, and his pulmonary artery pressure is returned to essentially normal following intervention, which is great. So we all high-five each other, and we say, that's great. We get the patient off the table. He's feeling better. He's less hypoxic. His O2 demand is less. His heart rate normalizes. But now what? So these patients, this is again, the critical part, and something that I was asked to talk about as part of another master class that was sponsored by Penumbra. If you think about what the patient is going through here, it's a lot for them to take in. So we've had a great outcome acutely on the table. We've stabilized them. We've unloaded their right ventricle. But what do we do next? So as I mentioned, these patients are anxious. They're frequently overwhelmed with what's going on. They're literally, some of these patients are trying to survive. They're confused about what happened. How did I get this clot? Where did it come from? I've never had a clot before. I didn't have any leg swelling beforehand. In addition, they have so many doctors. So a patient that is on the floor has a hospitalist, but that hospitalist may be different one week to the next. They may rotate off on the weekend. They've got an ICU doc. ICU docs are typically, at least in our hospital, are shift-based. So they may have one ICU doc from 12 to midnight and then another ICU doc from midnight to noon. If they came through the ER, they see another physician. If they have an interventionalist, like in this case, okay, if there's another doctor, they bring in a vascular medicine specialist or a hematologist. They want to know who their doctor is. Who's going to take care of me when I'm done with all this? Sometimes we throw all this complex medical language at them and a ton of, a alphabet soup of initials of, oh yeah, you had a DVT. Well, I thought I had a PE. Well, you do. You really, it's kind of a VTE. And okay, well, what did I really have? There's some patients here in Florida that a heavy Hispanic population, so there's language barriers sometimes. So patients really don't even know how to digest some of this stuff. So I think it's very important that what we do with them afterwards is addressed. So what are the barriers to this smooth transition? Well, again, I think it goes back to patient understanding. Do they really understand what this disease process is? Do they understand what it's going to take to recover? A lot of these patients have comorbidities, and a patient comes to mind recently that we treated that had a sigmoid colectomy, partial sigmoid colectomy for diverticulitis, ended up with a large postoperative PE, and he's trying to put together how does my colon affect the arteries feeding my lungs? And they just cannot put that together. So I think it's part of our job to teach them about all this. And there's some resources that we've started to use that I think helps get the message across. What about the process? It seems so obvious that there should be a process for these patients to go through when we're all done with not just the intervention, but the hospitalization, conversion to oral anticoagulant. So do you have a process? Who's in charge of creating this process? Again, we tend to focus on the technical success, how much clot did we get out, but we focus less on the follow-up because we're assuming that, well, somebody else is going to be doing it. And I think that that's wrong. Even in my own practice, my own partners have a different approach to taking care of these patients afterwards, not just in the hospital, but outside the hospital. So some ideas about how do we address this while the patient's inpatient. Again, patients respond very differently. How do you think you're going to communicate this best to the patient so that they understand? So you really have to know your patient. It's all about education, in my opinion. They have to receive this message multiple times in multiple different ways. And some patients will ask you a lot of questions, and they'll ask the same questions. So you have to review with them what happened. You have to speak very plainly to them and very clearly to them and answer all their questions. And you will find yourself repeating this over and over every time you round on that patient. Where did this clot come from? Well, probably from a vein in your leg. Well, I didn't notice anything. So be prepared to answer those questions and keep it simple. We've now used some of the PERT resources to create this little one-pager, front and back, that we can refer to. There's nice diagrams. It's very simplistic. There are videos that Rachel stars in, at least one of them. And so I think the key is, do you have access to those? Do you even know that they exist? And how do you incorporate them into the follow-up for these patients? Because again, I think it's very critical. So again, potential solutions. I mentioned the PERT Consortium and their efforts in providing education. They have printable materials. This is what we use. We put it front and back. It kind of helps to answer their questions. It's something that they can take. It's a tangible thing they can take home with them. They can show it to their mother or their wife or their husband. It's available in different languages. I think that's an incredible resource, and it's so simple. For the more sophisticated folks, I guess you could teach them how to get information from the web. I think you have to show them how to use that. In our area, we have a relatively rural area in the catchment area around Gainesville. You can teach them how to use the QR code on their phone and use resources that way. I mentioned the videos. We've tried playing this in the room using one of our nurse practitioners who rounds with us. I think these are very helpful, but the goal is just empowering your patient, getting them to understand what happened, what's going to happen before you go home, and what's going to happen after you get home. So who coordinates this care? Again, do you have a dedicated VTE coordinator? We don't. It's unfortunate. We try to make the case, but like all hospitals, they want to know, okay, how much is this going to cost us? And what are we going to gain from it? It's a very binary thing for them. Is it making them money or is it costing them money? So we've used our nurse practitioner. We make rounds. We have PAs as well. You really have to design the process, because what works one place is not going to work in another. I'll show you an example of some of that here in a minute. But you have to get patients to be part of their recovery. They have to have ownership. The way I think about this with PE recovery is, when it comes to my patients with PAD, getting them to understand the need for supervised exercise therapy. And this sometimes is not a real motivated group. And so getting them to actually participate, be an active participant in their recovery, can be quite challenging. When they go home, do they retain what we tell them? I mean, did they have another set of ears? I think it's important to have family to have another set of ears to listen to what we're telling them, because to them, like my gentleman before who was trying to recover from a sigmoid colectomy with a new colostomy, that's his focus. He's not focused on, okay, I have to make sure that I have my DOAC on board, or if I'm on warfarin, I have to have my INR check. So I think the social circumstances come into play there. Do they have a supportive family when they go home? Did they live by themselves? Or is transportation an issue? If you're going to go see me, if you're going to go see a cardiologist outpatient, if you're going to go see a hematologist, did they have transportation available? All parts of the puzzle here from a socioeconomic standpoint. We think the first outpatient office visit is critically important. Who's actually going to be receiving this patient, and are they comfortable in doing that? There are some primary care physicians that say, you know what, that's your deal, or that's cardiology, or that's vascular medicine, or it's hematology. Again, are they alone, or are they coming with family? What if they are follow-up in a different healthcare system? We have 3 healthcare systems here in Gainesville, if you count our system, the university, and the VA. And so sometimes they come in with a cardiologist that's a part of a different healthcare system. And so where are they going to follow up? And the joke is, you ask 10 MDs about how they do their follow-up, you're going to get 11 answers. So I think it's important, and just some data here on quality of life. We heard a little bit about that earlier. About 50% of these patients have a reduced exercise tolerance at 12 months. If we can improve that by intervening early and offloading that right ventricle, I think that that's going to be better. Certainly, the healthier you are to begin with, that's a better predictor. If you're overweight, you have pre-existing cardiovascular disease, those are poor predictors. A lot of these patients get very frustrated that they have no gas in the tank. They go home and they have this poor quality of life because their functional capacity is somewhat limited. They can't do what they're used to doing. They have poor sleep quality, and that just feeds this entire post-PE syndrome. Ton of variation in terms of how these patients are managed. We have effective programs in heart failure, atrial fibrillation after coronary event, and they've been shown to be effective. So I think we need to work towards that. As Rachel mentioned, some standardization probably would be helpful. Again, you got to get buy-in from the patient. They have to participate. How we go about doing that is critically important. This is just a little article from the Danish population showing that when they develop and they test out a dedicated, focused post-PE intervention program, that is actually, you get a high participation rate of patients, and the practitioners feel that it's quite effective. This is not what we're capable of, though. In our private practice and in our private hospital, we cannot do something this elaborate. It just involves too many moving parts. But we do have kind of an integrated care model, and this is kind of a work in progress. Make sure that they do see us. Do they understand what happened? Did they remember me? And we want to certainly minimize their future risk. We like the idea of having primary care physicians involved in this, even though it may be above what they're comfortable with. We need to let them know that Mr. Smith had a PE and an intervention, and he's now on oral anticoagulation, and because this is going to potentially affect his long-term care as well. We don't have the luxury of vascular medicine in our area, so we have to involve primary care. Again, competing hospital systems, what if they come in and they have a different cardiologist, or what if they are in a different healthcare system? Is there a need for follow-up echocardiography? Debatable in my mind. Who's going to manage their oral anticoagulation? Is that going to be somebody from hematology, or is that going to be primary care? What's the role of cardiac rehab? To me, this is a huge lapse. The cardiac rehab program, even for post-CABG patients in our facility, has basically fallen apart. But I think it's important that we document what we do and we track it, because we have to have a system in place. So let's return to our patient real quick. He actually returned to the ER 7 days later with chest pain, shortness of breath, anxiety. So he gets another scan, and you can see this is now what his scan looks like now. If you remember what he had before, he had this large obstructing clot in the right pulmonary artery. And as we do again, we calculate the RV-LV ratio. It's now less than 0.9. Here's his other side. You recall that the big occlusive segment here in the lower lobe pulmonary artery was occluded before, and there was a large filling defect here in the distal left pulmonary artery. Those are now gone. And this is the oblique reformatted images, again, showing what you had before and what we have now. So just remember that not all chest pain is PE. This patient did not have a repeat pulmonary embolus despite similar symptoms. So in my opinion, we can do better in what we're doing for these patients long-term with communicating better with them, educating them better, and then coordinating their care as an outpatient. I think a programmatic approach is way better than just a random effort and say, oh, go see your primary care. We've proven that this dedicated approach is good with other disease entities. And like with organizing pulmonary embolus response team, figure out what works for you in your practice, in your hospital, and your patients, but do something. Thank you.
Thank you, Brett. It certainly takes a village, and this is a great example, a disease state that's a great example of. And thank you for those practical pearls around patient education and completing the loop. I got to say, those PE imaging is amazing, especially in a patient who can't hold their breath for, DSA. I got to pick your brain sometime on optimizing my technique in it. But I know we're a little bit over time. Maybe room for one question. And I also want to thank Aido for keeping up on the Q&A. So I think we're pretty good on that end. Knowing what happened in the stroke space previously, and as this, as we mature here in this space, more data comes in. What can we envision in the next few years? Maybe Rachel, or any of you, to that matter, as a closing comment here. Door to diagnosis, door to decision making, right? Door to intervention. Is this something that we're heading towards?
Yeah, I think so. There's a great paper in a part paper that looked at for every 1 hour that you made a PE diagnosis earlier, the mortality decreased by 5%. So I think we have our work cut out for us. So I do think that that is critically important, and it goes to what we talked about earlier about having it on the differential. And so I think the door to stroke time, door to blue time, I think door to diagnosis and treatment, because there's also been studies that show, if you start people on anticoagulation, it decreases in hospital mortality and 30-day mortality. So I think that is critical. And just, Brett, going to what you were saying, that follow-up is so critically important too. If you look at kind of all the issues that Jaco brings up, it's just those transitions of care. And I think there's so many different ways to do it. And I think if you're thinking about what does this look like, you can embed your follow-up in a clinic that already exists. All the pulmonologists on this, you might have already a pulmonary clinic, or maybe you get your hematologist in, or maybe you get your vascular, or maybe you create a multidisciplinary. Ida and I did that before COVID, which was amazing. So there's always lots of different ways to do it. But I think having a system and not letting people leave the hospital without that system in place.
Great. Absolutely.
That's
Agree
especially
100%.
the strides.
Just do something.
Well, exactly. And then the strides we are taking from a data, from a technology perspective, having that multidisciplinary approach, I'm sure, is helpful. I know it's been late for Edo on the European time, but I truly appreciate all your insights. Great wisdom, great thoughts. I could go on for another hour, but we're given a time slot here. So thank you to all the faculty, and I look forward to having this conversation more in the future. Thank you to the audience for tuning in. Have a great rest of the evening. Appreciate it.
Thank you for having us. Thank you.
Thanks, guys.
Yes, thank you so much.
Thank you.